Well, thanks for the invitation. I really appreciate it, and for the introduction. I definitely drew the long straw on this one with this crowd, so I'm pleased with that. So today I'm tasked with answering the question, is MRA a good technique for procedure planning? Absolutely, it is. In fact, maybe it's not a good technique, maybe it's a great technique. This is my opinion, but I wanted to prove it to myself. So what I did when I was first given this topic, I literally looked back at my last 50 consecutive vascular interventions. They're listed in groups here, and just went through each one. How did I plan it? What was my main pre-procedure imaging technique? So just real briefly going through, here's a left upper extremity hand vascular malformation, pre-planning with MR, and then the intervention. Beautiful correlation. Splenic artery aneurysm, which you can see nicely on the CTA. Here's the corresponding angiography before and after intervention. Pelvic congestion syndrome, nice CTV. We see distended and large gonadal vein, periuterine venous plexus, and then a really nice correlation pre and post embolization. Bilateral lower extremity ischemia patient I had. Pre-procedure planning was done with MR. On the left side, there's superficial femoral artery and popliteal stenosis. These are treated with atherectomy and drug-coated balloon. Here's the superficial femoral and popliteal. Beautiful correlation between the MR and the angiography. And then finally, patient with hypertension and renal ischemia. It looks like we have a second-order branch vessel stenosis that looks pretty typical for fibromuscular dysplasia. This is obviously pre-procedurally evaluated with an MR, and angiographically beautiful correlation with the MR. Pre and post intervention. So I've used some MR and some CT, and then I grouped the different specific types of cases and tried to figure out where I had some areas of preference. For vascular malformations, I evaluated all of these patients with MR. The only ones that I pre-screened with anything other than MR were pulmonary AVMs. I used CT in that case. For lower extremity interventions, I did 100% of my planning with MR. The only times I used CT were if the patients came from an outside institution and they had a CT in hand. I just didn't feel like it was appropriate to order some tests that maybe were redundant. For renal and visceral arterial interventions, I used exclusively MR for pre-procedure planning. The only caveat was in this very small separate of post-biopsy renal AV fistula. These are diagnosed and really nicely seen with ultrasound. So that was the only pre-procedural imaging. Now moving to a little bit different tact, the aneurysms and pseudoaneurysms that I treated, I evaluated some with MR and some with CT, in fact with a small CT preference, about 2-to-1. And then the venous interventions, again, some with CT, some with MR, a bigger CT preference in that case, about 4-to-1. So I think there's going to be a significant practice dependence to how people utilize these different technologies. For me, MR is absolutely my first go-to in most of these patients. But if you happen to have a practice that really focuses on, say, treatment of aneurysms, or maybe focuses on venous intervention, you might be seeing, or you might be doing more procedure planning with CT. So once I came to this conclusion, which I kind of already knew already, I felt like I needed to justify it rather than just going with my instinct and my preference. Why am I making these choices? Well, for me in my practice, absolutely the most important thing with MR is I can get beautiful vascular imaging with low contrast or entirely non-contrast MR. I just can't do that with CT. And in my practice, and I think in a lot of people's practice, there's a significant group of patients that have significant renal insufficiency, and the whole idea of giving these patients iodinated contrast is antithetical. We just can't do it. It's just not an option. So MR provides really great pre-procedural imaging without that contrast bolus. So here, non-contrast MR, we see left external iliac artery stenosis. Beautiful correlation. The angiographic image looks a little hazy, of course, because that's CO2 angiography. So we're doing non-contrast pre-procedural imaging and then non-contrast intervention as well. Post-procedure looks nice. The other thing that I absolutely love about MR, and one of the main reasons why I like it for arterial interventions, is the ability to visualize the reconstituted vasculature distal to the occlusion. Here in this patient with right lower extremity rest pain, you see long segment SFA and popliteal occlusion with reconstitution right at the tibial trifurcation. Absolutely beautiful depiction of the outflow vessels. You can't do this with CT. You just can't. And then the intervention, pedal access, retrograde arteriography shows perfect correlation between the angiogram and the MR. We knew exactly where the arterial system was going to reconstitute on MR, and it's proven perfectly on angiography. Then retrograde recanalization, and now after intervention, antegrade angiography. And look at the runoff. Absolutely perfect correlation between the MR and the angiogram. This is an ideal pre-procedure planning technique, not just named vessels, but we're talking small side branches. And to be honest, the MR actually looks a little bit better than the angiogram. The other reason why I really like MR, I realized, is the tissue characterization component of it. I see a lot of patients with vascular malformations, and of course, you can make the diagnosis of malformation and you can plan treatment. But the bigger issue, once we treat these patients, we then retreat them again and again and again. This specific gentleman I've probably treated 6 or 7 times. He's probably got at least another half dozen before I'm finally done with him. And so what MR allows me to do is not only guide my initial intervention, but now I can see what areas have been treated and what parts of the malformation remain untreated, and I can target subsequent interventions. Super valuable, really helpful. There are some disadvantages to MR. I think we should at least touch upon them briefly. Magnetic susceptibility, I think, is the number one disadvantage of MR, at least for the interventional practice. It's not great for device assessment. Medical devices have metal in them, some of them more or less ferromagnetic, but it causes issues. This being a nice example, this patient had what was suspected to be right common iliac artery stenosis, and at the time of intervention, CO2 angiography, I don't see a stenosis, but when I magnify, what do I see? I see an embolized stent fragment. She has a renal artery stent that when we look up higher, it's actually fractured. So rather than having an occlusion to treat, I just had to knock this off to the side, get the wire through it, and treat it in a different way. So it can be misleading. In this case, we were able to do the procedure. Sometimes it can cause problems. This is a problem you guys are all familiar with. These aortoiliac kissing stents are patent, but are they completely patent? Is there stenosis or is there not? And with imaging like this, we just don't get all the information that we want. We get a lot, but not everything. And then, of course, the issue that I saw some people trying to address in some of these earlier discussions today is the motion sensitivity. If we can image faster, then we have less motion sensitivity. We've already seen this angiogram earlier. I showed that I had treated this patient's left iliac artery. There was also a question of something going on in the right iliac artery. As long as I was there, I took some pictures. As it turns out, there's nothing. This is motion or misregistration. Now, CT has some advantages that can address some of these issues. The primary thing for me, for CT, for planning interventional procedures, is the high spatial resolution when I need to make measurements using bony landmarks or measurements that involve an indwelling device. Specifically, and I think an area where this comes up with some frequency, is treating aneurysms, choosing an endograft that's going to be placed. CT, I think, rivals MR in that case. And also, in cases like this where I have an abdominal aortic aneurysm with a stent graft and a type 2 endoleak, which everybody can see, and I need to target that endoleak. I have to hit that small enhancing area. I can't just go in the endosac. I have to target that with a needle and not hit the endograft itself. And I can do that using markers on the graft that are visible on CT. I can't do that with MR. That allows me to get into this small component that's patent and then fill that with glue, treating that. The other area, and we've talked about this already, that I think CT rivals MR, is instant visualization. And this comes up a lot, more in, not necessarily in procedure planning, but patient follow-up and then potentially subsequent procedure planning. Big disadvantages. The iodinated contrast material is an absolute deal breaker. There are a lot of patients in whom I might get a CAT scan. I might actually prefer it to an MR, but it doesn't really matter because I can't get it. They can't get iodinated contrast material. We have some new CT technology that allows us to do half dose or even third dose CTA. It's inconsistent. It's just not as good and not as consistent as an MR. The other thing that we deal with frequency in CT is beam hardening. This being sort of an extreme example, we have a two-piece arthroplasty on the right, and you can see we even have streak artifact extending all the way to the left side, and the right is like just an explosion. You see absolutely nothing. One thing that I think is a big problem for me in treating vascular patients that may be a little bit underappreciated with CT is this concept of calcium blooming, the Hounsfield unit averaging of adjacent pixels. So this patient has heavily calcified, kind of block-like calcification in the external iliac artery. Is this a stenosis? Is it an occlusion? It looks like it's probably a really high-grade stenosis, but not an occlusion. At the time of intervention, wire went right past. Angiographically, there's no collaterals. Hemodynamically, there's no significant pressure gradient. There's no lesion here. I mean, there's atherosclerotic disease and it's calcified, but I didn't treat anything. So CT, if I weren't being thorough, might lead me to just go ahead and treat something that really doesn't need treatment like this. Similarly, this concept of calcium bloom can maybe talk you out of treating a lesion, thinking that it's not treatable, when actually it's quite straightforward. This is a patient with chronic mesenteric ischemia, and there's this really heavy kind of coral reef aortic calcification bridging the celiac and the SMA. And here on this image, it looks like complete occlusion of the celiac. We see a little bit of enhancement beyond the calcium. And of course, my first thought is that's just collaterals flow coming backwards. But when we use another modality, we use ultrasound, it shows us that the CT misled us. That was calcium blooming. There's actually a flow lumen there. Granted, it's high velocity turbulent flow. This is a significant stenosis, but there's a way we can get through that. So there's the calcium. Wire and catheter go straight through, and then after atherectomy and angioplasty and stent, we've recanalized a vessel that on that initial CT would suggest you can't even treat it. So I think this concept of calcium bloom is a big downside for CT, and there's the post-procedure follow-up. I think we should just very briefly touch on ultrasound. It's very physiologic, it's broadly available, but it also is very operator dependent, and where I live, in the middle west of the United States, body habitus is a big issue, and we're not getting great, consistent pictures. Also, the common problems of sound attenuation that everybody's familiar with. So, MR is great for stenotic and occlusive arterial interventions because it allows me to visualize distal to the occlusion. I can use it in patients with renal insufficiency, and I can also characterize tissue in non-atherosclerotic disease. CT's good. It's got some issues. It's really good for aneurysmal disease, where I need detailed measurements, or maybe if I need to visualize an existing implant. And it's also potentially rivaling MR on venous interventions. That said, if I'm stuck on a desert island and I just have to treat the people living there and I've got to choose one, the CT or the MR, I think I'm choosing the MR, like basically 10 days out of 10. Unless, of course, it's a strange desert island and there's a bunch of people with aneurysmal disease and things like that. Thank you.